In about 3 or 4 videos, we'll be talking about anticoagulants and antiplatelet agents. But in order to understand the mechanisms by which they work, we should know every single step involved in platelet aggregation and clot formation. So, in this lecture I'm gonna take you from A to Z, through a series of questions and answers. What is hemostasis? What happens in the normal conditions? And what happens when someone is injured? The first question, what is hemostasis? You'll be hearing this word so many times, so let's start by defining it. Hemostasis is the natural process that stops blood loss when an injury occurs. When the process of hemostasis becomes impaired, the ability to effectively stop bleeding is lost. In contrast, if the mechanisms involved in hemostasis and blood coagulation become overly active, unwanted clots may form within the blood vessels or tissues. Hemostasis involves 3 steps: vascular spasm, platelet plug formation, and coagulation. We're gonna talk about these in details, but first we should know clearly what happens in the normal conditions. Let's make an illustration of platelets circulating in blood vessels, healthy intact endothelium, and collagen fibers in the subendothelium, and a platelet having various types of receptors on its membrane. In the absence of injury, resting platelets circulate freely, acting as vascular guards, monitoring the integrity of the vascular endothelium. There are some chemical mediators synthesized by intact endothelial cells, and act as inhibitors of platelet aggregation, such as prostacyclin and nitric oxide. Prostacyclin, known as prostaglandin I2, acts by binding to platelet membrane receptors that are responsible for the synthesis of intracellular cyclic adenosine monophosphate, CAMP. This elevation in intracellular CAMP is associated with a decrease in intracellular calcium, and this stabilizes inactive glycoprotein 2b3a receptors, and inhibits release of platelet aggregation agents or calcium. So what happens when an injury occurs? The first thing happens is vascular spasm. It occurs immediately following injury to a blood vessel wall, to limit blood flow out of the vessel. This vascular spasm is believed to be mediated by Thromboxane A2, which is released both from circulating platelets in the area of injury, and the damaged endothelial cells themselves. Then, platelet plug formation occurs in 3 steps: adhesion, activation, then aggregation. Platelets are attracted to the area of injury, cover the exposed collagen of the subendothelium. This process is called adhesion. There is a protein released from endothelial cells, required for proper adhesion of platelets, called von Willebrand's factor. This protein is essential for allowing platelets to adhere to collagen, as well as to one another. Then receptors on the surface of the adhering platelets are activated by the collagen. This causes morphologic changes in platelets, or we can say they become sticky, and the release of platelet granules containing chemical mediators, such as adenosine diphosphate, Thromboxane A2, serotonin, platelet activation factor, and thrombin. Thromboxane A2, thrombin and serotonin activate phospholipase C, and the resulting acetyl-1,4,5 trisphosphate stimulates calcium release from the endoplasmic reticulum. ADP inhibits adenylyl cyclase, and the decrease in CAMP increases cytoplasmic calcium. All antiplatelet drugs act one way or another to inhibit these calcium-dependent pathways of platelet activation. That reminds us of prostaglandin I2, that is considered a physiological antagonist to these mechanisms. This increase in calcium causes 3 actions: the release of platelet granules containing mediators, such as ADP and serotonin, that activate other platelets, activation of thromboxane A2 synthesis, and activation of glycoprotein 2b3a receptors that bind to fibrinogen. Fibrinogen, which is a soluble plasma glycoprotein, simultaneously binds to glycoprotein 2b3a receptors on 2 separate platelets, resulting in platelet cross-linking and platelet aggregation. This process goes on, till forming a platelet plug. Then comes the third step, blood coagulation, Blood coagulation is the process in which fibrin protein strands wrap around the platelet plug to form an insoluble clot. The process of blood coagulation occurs through two separate but related pathways, called the intrinsic and the extrinsic coagulation pathway. The extrinsic system is initiated by the activation of clotting factor VII by tissue factor, also known as thromboplastin. Tissue factor is a membrane protein that is normally separated from the blood by the endothelial cells that line the vasculature. However, in response to vascular injury, tissue factor becomes exposed to blood. There it can bind and activate factor VII, initiating the extrinsic pathway. The intrinsic system is triggered by the activation of clotting factor XII. This occurs when blood comes into contact with the collagen in the damaged wall of a blood vessel. Both the extrinsic and the intrinsic pathways involve a cascade of enzyme reactions that transform various plasma factors, proenzymes, to their active enzymatic forms. Note that in the cascade, the active form of a clotting factor is the same as the factor plus the letter A. The final common sequence in both pathways involves a complex that includes activated factor X, factor V, platelet phospholipids and calcium that catalyzes the conversion of the serine protein prothrombin to thrombin. In turn, thrombin converts plasma fibrinogen to fibrin. Then fibrin monomers bind together forming a network that forms the insoluble clot. A final factor 13, called clot-stabilizing factor, is released by platelets trapped in the platelet plug, and stimulates polymerization and cross-linking of fibrin strands. Then comes the last step, fibrinolysis, the breakdown of fibrin. Once the damaged blood vessel is repaired, the fibrin clot is no longer needed, and must be removed from the blood vessel lining. This process of fibrinolysis or clot dissolution is accomplished by the enzyme plasmin, that digests the fibrin network. Plasmin travels in circulation as the inactive proenzyme plasminogen, and is activated by factors produced by the liver and vascular endothelium, called plasminogen activators. And there are two types of these activators: tissue plasminogen activator, TPA, and urokinase plasminogen activator, UPA. The activity of plasmin is in turn regulated by the inhibitory enzyme alpha-2 plasmin inhibitor, which rapidly inactivates it. There are also several inhibitors of coagulation factors, including protein C, protein S, antithrombin III. So we can summarize what happens when an injury occurs, or in other words, the steps of hemostasis, in a sentence. First, vascular spasm occurs to limit blood loss. Then platelet adhere to collagen and the subendothelial cells, then get activated and release their contents. Then aggregate, forming a platelet plug. Then blood coagulation cascade starts, forming fibrin network, leading to an insoluble clot. And when healing occurs, plasmin digests fibrin and dissolves the clot. And that's it. In the previous lecture we discussed an introduction about hemostasis, and how the body responds to an injury. So in this lecture we'll start talking about the drugs that are used to either prevent or dissolve unwanted clots that may arise in the blood vessels, under some pathological conditions. We already know from the previous lecture that we have three main mechanisms involved in the clot formation and dissolution: platelet aggregation, blood coagulation, and fibrinolysis. So we can conclude that the drugs used to stop any of these mechanisms can be classified to antiplatelet drugs, anticoagulants and thrombolytic agents, also known as fibrinolytics. Today we'll discuss the antiplatelet drugs. We already know from the previous lecture that platelet activation process depends on several chemical mediators such as Thromboxane A2, adenosine diphosphate, thrombin, serotonin and collagen. These platelet activators promote the conformational change needed for the glycoprotein 2B3A receptor to bind ligands, particularly fibrinogen. fibrinogen simultaneously binds to glycoprotein 2b3a receptors on two separate platelets, resulting in cross-linking and aggregation. So we can conclude that antiplatelet drugs can be classified to thromboxane A2 inhibitors, ADP receptor inhibitors, and glycoprotein 2b3a inhibitors. Let's start by thromboxane A2 inhibitors. The famous drug, aspirin, in small dose of 75 to 150 mg works as thromboxane A2 inhibitor. So what is the exact mechanism? Stimulation of platelets by thrombin, ADP and collagen, results in activation of platelet membrane phospholipase that liberate arachidonic acid from membrane phospholipids. Arachidonic acid is first converted to prostaglandin H2 by COX-1. Prostaglandin H2 is further metabolized to thromboxane A2, which is released into plasma. And we know the rest of the story. Thromboxane A2 promotes the aggregation process. So what aspirin does is that it irreversibly inactivates the enzyme COX-1, leading to inhibition of thromboxane A2 synthesis, thereby preventing platelet aggregation. Aspirin is used in the prophylactic treatment of transient cerebral ischemia, and to reduce the incidence of recurrent myocardial infarction. The second category, adenosine diphosphate inhibitors. Clopidogrel, Ticlopidine, prasugrel, and ticagrelor. These drugs inhibit the binding of ADP to its receptors on platelets, and thereby inhibit the activation of the glycoprotein 2b3a receptors, required for platelets to bind to fibrinogen and to each other. Clopidogrel is approved for prevention of atherosclerotic events, in patients with a recent myocardial infarction or stroke, and in those with established peripheral arterial disease. It is also approved for prophylaxis of thrombotic events, in acute coronary syndromes. Ticlopidine is indicated for the prevention of transient ischemic attacks and strokes, in patients with a prior cerebral thrombotic event. Prasugrel is approved to decrease thrombotic cardiovascular events, in patients with acute coronary syndromes. Ticagrelor is approved for the prevention of arterial thromboembolism, in patients with unstable angina and acute myocardial infarction. The third category is the glycoprotein 2b3a inhibitors. It includes Abciximab, eptifibatide, and tirofiban. They simply inhibit the glycoprotein 2b3a receptor complex by blocking the binding of fibrinogen and von Willebrand factor, leading to inhibition of aggregation. These agents are given intravenously, along with heparin and aspirin, as an adjunct to percutaneous coronary intervention, for the prevention of cardiac ischemic complications. And the last two agents are Dipyridamole and Cilostazol. Dipyridamole, a coronary vasodilator, increases intracellular levels of CAMP, resulting in decreased thromboxane A2 synthesis. It is used for stroke prevention, and is usually given in combination with aspirin. Cilostazol is an oral antiplatelet agent that also has vasodilating activity. Cilostazol and its active metabolites inhibit phosphodiesterase type 3, which prevents the degradation of CAMP, thereby increasing levels of CAMP in platelets and vascular tissues. This increase in CAMP levels in platelets and the vasculature prevents platelet aggregation and promotes vasodilation of blood vessels. This drug is approved to reduce the symptoms of intermittent claudication. We already know from the previous lectures what is the coagulation cascade, but we can summarize it, then talk about the anticoagulant drugs mechanisms. Blood coagulation is the process in which fibrin protein strands wrap around a platelet plug to form an insoluble clot. And this is done through two pathways, intrinsic and the extrinsic pathways. Both pathways have a common sequence, involves a complex that includes activated factor X, factor V, platelet phospholipids and calcium, that catalyzes the conversion of the serum protein prothrombin to thrombin. In turn, thrombin converts plasma fibrinogen to fibrin. Then fibrin monomers bind together, forming a network that forms the insoluble clot. There are two important information you should know. Vitamin K is required for the synthesis of several coagulation factors. There are several endogenous inhibitors for the coagulation process. The most important one we should mention is antithrombin III. It binds to thrombin and to factor Xa, and deactivates both of them. The main goal of anticoagulant drugs is preventing the formation of fibrin, leading to inhibition of clot formation. So there are four main sites that drugs can act on, and inhibit or activate, according to its action. Activators of antithrombin III, vitamin K antagonists, direct thrombin inhibitors, and selective factor Xa inhibitors. Today we'll discuss the activators of antithrombin III, unfractionated heparin, and low molecular weight heparins, and they include enoxaparin, dalteparin, tinzaparin and Nadroparin, and the synthetic pentasaccharide, fondaparin. Let's start by defining them. Heparin is a naturally occurring highly acidic glycosaminoglycan of varying molecular weight from 5,000 to 15,000. It occurs naturally as a macromolecule, complexed with histamine and mast cells, and is extracted for commercial use from porcine intestinal mucosa. Low molecular weight heparins are heterogeneous compounds, about one-third the size of unfractionated heparin. And as we said, fondaparin is a synthetic pentasaccharide. They are administered intravenously or subcutaneously. So what is the exact mechanism of action? Heparin binds to antithrombin via its pentasaccharide sequence. This induces a conformational change in the reactive center loop of antithrombin that accelerates its interaction with thrombin and factor Xa. And there is another mechanism heparin does. To potentiate thrombin inhibition, it must simultaneously bind to antithrombin and thrombin, which is called bridging. But only heparin chains composed of at least 18 saccharide units, that corresponds to a molecular weight of 5,400, are of sufficient length to perform this bridging function. Low molecular weight heparins have greater capacity to potentiate factor Xa inhibition than inhibition of thrombin by antithrombin, because low molecular weight heparin's chains are too short to bridge antithrombin to thrombin, as it has lower molecular weight than heparin. And the last agent, fondaparin, which is a synthetic pentasaccharide, only accelerates factor Xa inhibition by antithrombin, because the pentasaccharide is too short to bridge antithrombin to thrombin. Let's now talk about their therapeutic uses. These drugs are used in the treatment of acute venous thromboembolism, deep venous thrombosis or pulmonary embolism. They are also used for prophylaxis of postoperative venous thrombosis, in patients undergoing surgery, and those with acute myocardial infarction. A very important information you should know, these drugs are the anticoagulant drugs of choice for treating pregnant women, because they do not cross the placenta, due to their large size and negative charge. So what about their adverse effects? The most common adverse effect of heparin and low molecular weight heparins therapy is bleeding. So dose should be monitored closely, especially with heparin. Excessive bleeding may be managed by discontinuing the drug, or by treating with protamine sulfate. It combines ionically with heparin to form a stable, 1-to-1 inactive complex. Fondaparin is not neutralized by protamine sulfate, and there is no antidote available to counteract bleeding disorders associated with overdosing. Hypersensitivity reactions may occur with heparin preparations, as they are obtained from porcine sources, so they may be antigenic. Reactions include fever, urticaria, chills, and anaphylactic shock. Heparin-induced thrombocytopenia is a serious condition that may also happen. This condition is characterized by an abnormally low number of platelets circulating in the blood. It is an immune-mediated reaction, that carries a risk of venous and arterial embolism. Heparin-induced thrombocytopenia is less likely with fondaparinux than with heparin, but is still a possibility. Osteoporosis has been observed in patients on long-term heparin therapy. Fondaparinux is eliminated unchanged in urine, so it is contraindicated in patients with severe renal impairment. Low molecular weight heparins have largely replaced unfractionated heparin, because they have a longer half-life than standard heparin, so they require only a single daily dose by subcutaneous injection. Prophylactic doses do not require monitoring, and thrombocytopenia is rare. And fondaparinux may be superior to low molecular weight heparins. We're gonna talk about the vitamin K antagonist, the very famous drug, Warfarin. Let's start by the mechanism of action. Factors 2, 7, 9 and 10 require vitamin K as a cofactor for their synthesis by the liver. Warfarin acts by preventing the production of vitamin K, by inhibiting vitamin K epoxide reductase. So it breaks the loop, and prevent the activation of these coagulation factors by carboxylase. It inhibits factor 2, which is prothrombin. So prevents the formation of thrombin. Subsequently prevents the formation of fibrin, so prevents the clot formation. Warfarin is used in the prevention and treatment of deep venous thrombosis and pulmonary embolism, thromboembolic disorders, and stroke prevention in the setting of atrial fibrillation. Adverse effects of warfarin include bleeding. Minor bleeding may be treated by withdrawal of the drug, or administration of oral vitamin K. But severe bleeding may require higher doses of vitamin K given intravenously. Skin lesions and necrosis are rare complications of warfarin therapy. Cholesterol microembolization. Warfarin is teratogenic, and should never be used during pregnancy. Let's finally talk about pharmacokinetics and drug interactions with warfarin. Warfarin is rapidly absorbed after oral administration, 100% bioavailability. The mean half-life of warfarin is approximately 40 hours, but with high individual patient variation. And it has a duration of action from 5 to 7 days. Warfarin readily crosses the placental barrier, and it is not excreted in breast milk. It is highly bound to plasma albumin. So drugs that affect warfarin binding to plasma proteins can lead to variability in the therapeutic response to warfarin. For example, sulfonamides has a greater affinity for the albumin binding site, so it can displace warfarin, leading to a transient elevated activity of warfarin. Warfarin is metabolized by the enzymes of the liver. Then the inactive metabolites are excreted in urine and feces. Agents that affect the metabolism of warfarin may increase or decrease its therapeutic effects. For example, enzyme inducer drugs, such as phenobarbital, increase the metabolism of warfarin, so decrease warfarin's effect. And enzyme inhibitors drugs, such as erythromycin, decrease the metabolism of warfarin, so increase warfarin's effect. The third type, the direct thrombin inhibitors. These agents directly inhibit thrombin, subsequently prevents the formation of fibrin, so prevents the clot formation. And they can be classified to parenteral and oral agents. The parenteral agents include bivalirudin, desirudin, lepyridin, and ergotroban. And the oral agent is dabigatran. Bivalirudin, desirudin and lepyridin are parenteral anticoagulant drugs that are analogues of hirudin, which is a thrombin inhibitor, derived from medicinal leech saliva. Bivalirudin is an alternative to heparin in patients undergoing percutaneous coronary intervention. Desirudin is indicated for the prevention of deep venous thrombosis in patients undergoing hip replacement surgery. Lepyridine is used for patients with thrombosis, who already have, or at risk for developing heparin-induced thrombocytopenia. Dosage adjustments for these agents are required in patients with renal impairment. Argatroban is a synthetic parenteral anticoagulant that is derived from L-arginine. It is used for the prophylaxis or treatment of venous thromboembolism in patients with heparin-induced thrombocytopenia, and it is also approved for use during percutaneous coronary intervention in patients who have, or at risk for developing heparin-induced thrombocytopenia. It is metabolized in the liver, so it may be used in patients with renal dysfunction, but it should be used cautiously in patients with hepatic impairment. Like the other anticoagulant drugs, bleeding is the major side effect of these agents. Let's now talk about the oral agent, dabigatran ethoxylate. It is the prodrug of the active moiety dabigatran. It is used in the prevention of stroke and systemic embolism in patients with non-valvular atrial fibrillation. It can be used as an alternative to enoxaparin for thromboprophylaxis in orthopedic surgery. And again, the major adverse effect, like other anticoagulants, is bleeding. But the good news is that there is an antidote to reverse the effect of dabigatran. It is called Dipyridamole. It is a monoclonal antibody fragment, indicated in patients treated with dabigatran when reversal of the anticoagulant effects are needed, for emergency surgery or urgent procedures, or in the event of life-threatening or uncontrolled bleeding. Gastrointestinal adverse effects are common with this drug, and may include abdominal pain, dyspepsia, esophagitis, and gastrointestinal bleeding. Dabigatran should be used with caution in renal impairment. It shouldn't be suddenly stopped, as patients may be at increased risk for thrombotic events. The last type, the selective factor Xa inhibitors. This category of drugs include the parenteral agent, fondaparinux, and oral agents, rivaroxaban and apixaban. Fondaparinux is a synthetic pentasaccharide that selectively inhibits factor Xa by selectively binding to antithrombin III. So it potentiates the neutralization of factor Xa by antithrombin III by about 300 to 1000 folds. It is approved for use in the treatment of deep venous thrombosis or pulmonary embolism, and for the prophylaxis of venous thromboembolism. Fondaparinux is eliminated unchanged in urine, so it is contraindicated in patients with severe renal impairment. Like the other anticoagulant drugs, bleeding is the major side effect, and there is no antidote available to counteract bleeding disorders associated with overdosing. Let's now talk about the other two drugs, rivaroxaban and apixaban. Both agents are oral inhibitors of factor Xa. They bind to the active site of factor Xa, so prevent its ability to convert prothrombin to thrombin. Rivaroxaban is approved for treatment and prevention of deep venous thrombosis and pulmonary embolism, and for the prevention of stroke and non-valvular atrial fibrillation. Apixaban is used for stroke prevention and non-valvular atrial fibrillation. And again, the major adverse effect, like other anticoagulants, is bleeding. And no antidote available to reverse bleeding caused by these agents. These agents are renally eliminated, so they shouldn't be used in severe renal dysfunction. And finally, they shouldn't be suddenly stopped. This category of drugs acts by converting plasminogen to plasmin that simply degrades and dissolves fibrin clots. Fibrinolytic drugs may lyse both normal and pathologic thrombi. This category of drugs include alteplase, reteplase and tenecteplase, urokinase, streptokinase, and istraplase. Alteplase was known as tissue plasminogen activator, or TPA. It is a serine protease that was originally derived from cultured human melanoma cells. But it's now obtained as a product of recombinant DNA technology. Reteplase is a genetically engineered, smaller derivative of recombinant tissue plasminogen activator. 10-ecteplase is another recombinant tissue plasminogen activator that has a longer half-life and greater binding affinity for fibrin than alteplase. Alteplase has a low affinity for free plasminogen in the plasma, but it rapidly activates plasminogen that is bound to fibrin in a thrombus or a hemostatic plug, so for this reason, alteplase is said to be fibrin selective at low doses. It has a very short half-life of about 5 to 30 minutes. Alteplase is approved for the treatment of myocardial infarction, massive pulmonary embolism, and acute ischemic stroke. It may cause orolingual angioedema, and this risk may be increased when combined with angiotensin-converting enzyme inhibitors. Reteplase and 10-ecteplase are approved only for use in acute myocardial infarction. Reteplase may also be used off-label, in deep venous thrombosis and massive pulmonary embolism. Both agents have longer half-lives than alteplase. Urokinase is produced naturally in the body by the kidneys. It directly cleaves the arginine-valine bond of plasminogen, converting it to the active plasmin. It is only approved for lysis of pulmonary emboli. It may also be used off-label, in the treatment of acute myocardial infarction, arterial thromboembolism, coronary artery thrombosis, and deep venous thrombosis. Its use has largely been supplanted by other agents, with a more favorable benefit-to-risk ratio. Streptokinase works by forming an active 1-to-1 complex with plasminogen. Then this enzymatically active complex converts uncomplexed plasminogen to the active enzyme plasmin. It catalyzes the hydrolysis of fibrin plugs, as well as catalyzing the degradation of fibrinogen, and the clotting factors 5 and 7. Streptokinase is rarely used now, and is no longer available in many markets. And finally, anistriptase. It is an acylated form of the streptokinase plasminogen complex. Acylation makes the complex temporarily inactive. After deacylation, which begins immediately after injection, the streptokinase plasminogen complex promotes thrombolysis, by speeding the conversion of plasminogen to plasmin. It lyses coronary artery thrombi, when given intracoronary or intravenously. That's all for this video. In the next lecture we'll talk about the drugs used for bleeding. So subscribe and wait for the next video.